Hello, ladies and gentlemen. My name is Darren Brenner, and I'm an Associate Professor of Medicine and Surgery in the Northwestern University Feinberg School of Medicine. I'm honored to participate in this IFFGD 2020 virtual advocacy event and to discuss the best ways to describe pain so that your healthcare practitioner best understands. Naturally, I'll be focusing on GI pain, and I'm going to use a common disorder, biliary colic, as an example of the types of things to tell your practitioner and how this plays a large role in coming to an efficient and accurate diagnosis. But before we discuss all this, I think it's important for us to understand why we concern ourselves so much with pain. One, if not the major reason, is because it's the most common presenting symptom and diagnosis made by GI practitioners. What I'm showing you here is the most recent National Ambulatory and National Hospital Medical Care Survey data evaluating GI symptoms and diagnoses on the left. And on the left, the table reveals that abdominal pain is the most common GI symptom, prompting an outpatient evaluation. In fact, the number of visits, almost 22 million, is a higher volume than all the other top 10 presenting symptoms combined. In the table on the right, abdominal pain is also the most commonly diagnosed disorder, and this diagnosis is made more than 3 times more frequently than the second most common diagnosis, which is reflux-based disorders. And it may seem like a simple task to describe pain, but it's actually quite difficult because pain is a complex and characterized by multiple factors. One, it can be hard to put the subjective sensations of pain into words or context. Two, it can be represented by many different symptoms, with individuals describing pain not as pain per se, but as a generalized discomfort, bloating, or distension. And three, most think that there's a standard definition, so they just say pain and assume that the practitioner knows what he or she means. But it turns out that each individual perceives pain in a different way. So let's begin with the standard definition of pain as defined by the Merriam-Webster Dictionary. Pain is defined as localized or generalized unpleasant bodily sensations that cause physical discomfort and or emotional distress and typically results from bodily disorders. A key point here is that pain can cause emotional distress, and that distress can subsequently worsen the pain sensations, resulting in a cyclic process. Thus, it's important to ask individuals with pain, especially chronic pain, whether they've developed situational anxiety and/or depression, and treat this component of the symptom profile accordingly. So how do you discuss pain with your practitioner? Here's how the beginning of a standard visit may go. The practitioner asks the open-ended question, "How may I help you?" And the patient responds, "I'm experiencing a lot of pain." The practitioner then tries to narrow the field by asking, "Okay, could you be a bit more specific?" And the patient responds with, "What would you like to know?" And that's a very appropriate question. So as practitioners, what do we really want to know? This is a very simple summary of the things we try to address when talking about pain. We call it the PQRST plus ERA, or as the name implies, position, quality, radiation, severity, timing, plus exacerbating or alleviating factors. To characterize why each of these is important, let's go back to the disorder I spoke of earlier, biliary colic, and see how certain responses lead us to that diagnosis. Biliary colic or pain in the gallbladder is usually related to the presence of gallstones in the gallbladder. And if you're not familiar with this disorder, that's okay. The point of this exercise is to understand how using the PQRST plus EA model can simplify the process of figuring out what's going on. So let's begin with P, or position. With position, historically we break the abdomen into 4 quadrants, but perhaps a better way is to look at it more like a tic-tac-toe board. And you can see that there are multiple GI maladies which can be defined based on where the pain is. That being said, there are more than just GI organs in the abdomen, so sometimes we see individuals with kidney, gynecological, urinary, neuropathic, musculoskeletal, or surgical issues. We have to think outside the realm of our own practice sometimes when thinking about pain. With respects to our example of biliary colic or gallbladder pain, we know that the gallbladder is located in the right upper quadrant of the abdomen, so someone with biliary colic will usually present endorsing pain in that position. Radiation, or where the pain goes after it begins, can also be a helpful indicator of the cause. Many pain disorders in different organs can radiate the pain in characteristic patterns. In our example of biliary colic, again, the pain begins in the right upper quadrant, which is the position, and typically radiates to just below the breastbone or bottom of the sternum, into the right side of the back, and or up towards the right shoulder or scapula. So if patients present with this characteristic pattern to describe these changes, again, this helps us to reduce the potential number of possibilities causing the pain. The severity of the pain is a subjective assessment and rating of how bad the pain feels. This can be different from one person to another, as some individuals have higher pain thresholds. However, certain disorders are associated with higher or lower levels of pain compared to others. You can see that there are multiple different pain rating scales which are commonly used in clinical trials, but most practitioners will ask for the pain to be rated on a 0 to 10 point scale, with 0 representing no pain and 10 the worst pain ever. The scales shown here are to provide you with a sense of how we perceive pain based on your subjective score. With respects to biliary colic, the characteristic pattern is a higher level of pain initially, followed by less severe pain before it goes away. Timing can also help us identify the source of the pain. For example, pains due to abdominal musculoskeletal disorders usually present with bodily position changes, or with simple maneuvers like coughing, sneezing, or laughing. These maneuvers lead to contraction or tightening of the muscles of the abdominal wall, and the tightening causes the pain. In our biliary colic example, the pain classically develops after a meal, especially a fatty meal, when the gallbladder contracts to release fluids which help us digest fats. When the gallbladder contracts, a gallstone, if present, may be pushed against or into the duct which drains the gallbladder. As the fluid is unable to exit the gallbladder swells and contracts more vigorously, leading to the pain. The pain classically begins after a meal, increases for the next 30 to 60 minutes, then remains at a lower intensity for the next few hours before it finally resolves on its own. And finally, as their names imply, exacerbating factors are things which make the pain worse, and alleviating factors are those which make the pain better. In the case of biliary colic, as we just mentioned, eating, especially fatty foods, induces or exacerbates the pain, and time alleviates it. So now that we're familiar with our PQRST plus E and A's, let's piece this puzzle together. Providing these simple responses, the pain begins in the right upper quadrant, is sharp to achy in quality, radiates to the chest, right side of the back and or shoulder, is at its worst for the first 30 to 60 minutes, then dissipates over the next few hours, and is most frequently induced by a fatty meal, provides us with an almost textbook diagnosis of biliary colic, despite the fact that at this point no diagnostic studies have been completed, and it underscores the importance of a good history when provided. One last thing we should never ignore, and if your practitioner doesn't ask, please make sure you describe how your pain syndrome is affecting your quality of life. This provides your practitioner with a better overall understanding of the impact the pain is playing in your day-to-day life, including your ability to function at home, with your family, socially, and in other potential arenas. A more significant impact may alter the diagnostic or therapeutic strategy undertaken, and remember that the emotional impact of these changes may be worsening of the pain itself. In summary, I'd like to leave you with a few clinical pearls. First, pain is the most bothersome and common symptom leading to a GI evaluation, and the diagnosis is made most frequently by GI practitioners. A good history can help differentiate between the multitude of causes for abdominal pain. Providing your practitioner with the PQRST plus E's and A's may lead to an efficient diagnostic and treatment strategy. And finally, make sure you describe how the pain is impacting your quality of life. I'd like to thank you all for your time and attention.